Good morning. Welcome to the Department of Medicine Ground Rounds. Today we're going to talk about oxygen therapy, which explains a little bit what you're seeing on the stage. Okay? But before that, a few comments. First of all, today was the birth in 1950 of James Rothman. You probably don't know James Rothman, but he was a Nobel Prize winner who, together with Checkman and Sofhoff, engage in studies related to vesicle trafficking. How does a cell transport information and cargo from one place to another, from one organelle to another? How do you fuse those membranes? How do you ensure that things go where they need to go? And that's a very interesting story. Today, November 3, 12:45 a.m. in the morning, since 1908, the Cubs win the World Series. Congratulations to the Cubs. Yes, please. Okay, but today is about the lung. So I want you to know Dr. Edward Kuehler Hammond. Dr. Edward Kuehler Hammond died on this day back in 1986, and 7 or 8 years before the Surgeon General's very famous report on smoking and health. He actually appeared before Congress while he was director of the American Cancer Society, and he said the following: evidence that smoking is a serious health hazard has been accumulating slowly since about 1950. Recent studies have produced overwhelming evidence that cigarette smoking is a causative factor of great importance in the occurrence of lung cancer. He continued by saying that the alarming trend in the death rates from lung cancer, with the numbers rising from 2,500 in 1930 to 29,000 in 1956, and last year it was over 160,000 deaths related to lung cancer, and in this country and most developed countries related to tobacco exposure. So remember Edward Kuehler Hammond. I also want you to know about Bernardino Ramazzini. I like those terms. Bernardino Ramazzini was an Italian physician born in Capri on this day, back in 1633. And he was the first who began to record the relationship between occupation and occupational hazards and disease, particularly respiratory disease. And in fact, he's considered the father of occupational medicine. He made it popular to sit down with a patient and said, "What do you do for a living?" And started reporting how those connections between occupation and disease were important. He started advocating for the use of face masks. This is in the late 1600s. Okay, you should know this. And in 1700, he published De Morbis Artificum Diatriba, which is considered the first treatise that correlates occupational medicine and environmental health. This was 49 years before the birth of Daniel Rutherford. Now, the speaker today may tell you a little bit about oxygen, about Priestley, and all these people who worked on oxygen in the late 1700s, but you need to know who Daniel Rutherford is. Daniel Rutherford was born on this day back in 1749. He was a Scottish chemist and photographer who discovered the portion in air that does not support combustion, which we know is nitrogen. But basically, he put a mouse in a little cage, hermetic cage, had a certain limited amount of air. The mouse breathes in there until it dies. Then he turns on a candle until the candle is extinguished. And there was some gas left, which he assumed it was carbon dioxide. So he processed that to get rid of the carbon dioxide. And there was a little bit of gas left. And he assumed that gas was what he called phlogisticated air. And phlogisticated air is called that way because there was the phlogisticon theory, that was a fire element within combustible bodies, that when they combust, that element is released, okay? And so the gas that he discovered was the gas that no longer was containing oxygen or any combustible material, phlogisticated air. Daniel Rutherford, born on this day in 1749. And so with that, I want to introduce our speaker of the day, a gentleman that I've known for quite some time, Dr. Rafael Perez, who was born back in March of 29 in 1956 in Madrid, Spain. He moved to the States with his family. He went to the University of Tennessee for his microbiology degree. I didn't know you were a microbiologist, Ralph. Then he went on to Memphis, University of Tennessee, to obtain his medical degree. He did internship and residency at Dayton, Ohio at Rice State, and moved on to Emory University to do fellowship in the mid-1980s. And I met Ralph and his wife in 1990 while I was being recruited to Emory University. Ralph rose through the ranks at Emory University, became associate professor there, obtained several awards for service and as well for teaching, and established, with the collaboration of others, the Interstitial Lung Disease Program and Center at Emory University. And we were lucky enough in 2009 to bring him to the University of Louisville, where he has also established another well-known interstitial lung disease program. He is currently professor of medicine. He is chief of the medical service at the VA. He's vice chairman of the Department of Medicine for VA Affairs, and he's director of our interstitial lung disease program. He's involved in a number of committees. He's involved nationwide in committees and foundations and organizations related to idiopathic pulmonary fibrosis and other interstitial lung disorders. In 2012, he won the Best Teacher Award in Pulmonary Medicine here in Louisville. And he's a beloved teacher and mentor for many of our students. And with that, I'll leave you with Dr. Rafael Perez, who's going to teach you about how to use this.
Oh, shucks. Thanks. Thank you, Jesse. Good morning, everyone. Shout out to my folks at the VA, my colleagues, fellows, residents, and medical students. I'm taking names, so please be watching. So thanks. I decided to take this opportunity to do something that I do when I'm on service on the consult rotations. I like to engage our residents and fellows and explain to them a little bit about oxygen delivery. You know, this is something that I don't think we do very well because there are many devices out there to deliver oxygen. Dr. Roman was wearing just one of them. And when I saw that, I was thinking about maybe I should have brought a table where we could lay out stuff and he could stand back there and do a Vanna White and kind of demonstrate the different oxygen delivery devices we'll be talking about today. So this is a great opportunity to go to a wider audience and talk about the different types of devices. I'm going to be showing you a lot of images, probably more than you get from a Jeff Callan dermatology lecture, but they're not gross like his images. Okay. So here are my disclosures. We have several ongoing clinical trials. I'm not on any speakers bureau, and maybe by the end of this talk you'll understand why. So the objectives for today, I'd like to really do this in 3 parts. I want to spend a little bit of time, maybe a third of the time, talking about the anatomical and functional aspects of the lung that I think we need to think about when we're considering different types of oxygen therapy, especially when the lung is abnormal. I'm going to be talking about the normal lung, but then kind of going back and forth and making you think about the diseases that affect the different parts of our lungs, all the way from the conducting airways down to the gas exchange surface area, and to give you some idea on how you might want to think about which specific oxygen device you might want to use in the acute setting or even in the home care setting. And so the last 2 pieces of my talk today will look at the principles and rationale for looking at modes of oxygen delivery systems in the acute care setting, and then I'll finish off by talking about how we approach home oxygen therapy in the hopefully stable patient once they leave the hospital or they're referred to us from the clinic. I want to start with this gentleman. This is way after Priestley. I did have Priestley there, but I took him off because it would have made this lecture too long. This gentleman is Dr. Ewald Weibel, one of my heroes in terms of understanding how the lung looks and how the lung works. He got his MD in 1955 at the University of Zurich, and then immediately came to the States, where he went to Yale, Columbia, and the Rockefeller Institute, where he learned pathology, cardiorespiratory physiology, and cell biology. So he took all of this and has mentored many people over the years. And has essentially joined the anatomic structure of the lung with its function. And I'm going to show you some of his work here and try to develop that theme of lung structure begets function. So here's just kind of an agglomeration of some of the work that he's done. In the panel on the upper, well, to your left, is an actual cast of a human lung. The right lung shows a plastic cast of all of the conducting airways. And on the left lung, we see the conducting airways, but we also see the vasculature that permeates the lung. Now, Dr. Weibel made a mistake here, and for the sake of time, I'm not going to ask you what the mistake was, but I'll tell you. So here what you see in red is the pulmonary arterial system. And as we all know, that's coming from the right heart. That blood should be blue. It shouldn't be red. And then in the blue, we have the pulmonary venous system, which comes back to the left atrium, and that's where all the oxygenated rich blood should be. So he should have transposed those colors. But the point there's several points I want to make by showing you this cast. First, we can look at this nice summary chart here. In a 70-kilogram healthy adult human, it seems like 70 kilograms is what we consider average in all of our text and so on. The lung weighs the wet lung weight is about 1.3 kilograms. You can see the lung volume here at about 4.34 liters. And the alveolar surface area is about 130 meters squared, which is just a little bit under the surface area of a singles tennis court. Okay, so there's a lot of surface area that we're packing into our very small chests. The capillary surface area, of course, as you know, the capillaries abut very closely the alveolar side. It's about 115 square meters, and of course, it's that network, so there are spaces in there. As I'll show you later in some scanning micrographs, the capillary blood volume doesn't seem like a lot to spread 194 mLs over the surface area of a singles tennis court. We have about 480 million alveoli. Now, one of the things that Dr. Weibel and his group in the 1960s understood, and they were trying to understand the hydrodynamics or the engineering of the lung. And what they noted was that the way that the lung branches, it does it in this pattern. And everyone is familiar with Mandelbrot and fractals. Okay, so basically, with each branching, we get these self-similar branching patterns. As you can see, this big branch here looks like these smaller branches, look like these smaller branches. And if you can imagine these things kind of curling around each other and so on, so that you have a branching pattern that may be abutting the heart, which is very similar in structure and in length as it is if it's coming out to the pleural space. Now, if you take all of these little conducting airways and add them end to end, in this 70-kilogram healthy adult human, it'll stretch out to 2.4 kilometers, right? So that's pretty impressive, and how does the lung put all this together for making it function? Another important piece I want to show you is I mentioned that there's branching, and here on this graphic on the y-axis we have the average airway diameter in millimeters, and pay particular attention to this. I'll be getting back to that. And we have here the trachea, and as we branch down, these are the conducting airways, and they diminish by this function. Really, it's the cube root of 1/2. And so with each branching, the branch diameter goes down by, it's about 0.8 of the previous branch. And what that turns out to be is the most efficient, optimized hydrodynamic shape and change in lung to decrease airways resistance and dead space as well. So nature has found the best engineering for conducting air into our lungs. So we can see here this decrease in the branch points along that specific function. And then when we get to the transitional zone here and then into the respiratory bronchioles, the alveolar ducts, and the air sacs, you can see here that obviously the slope changes and the dynamics change, but then we change into a situation where gas transfer becomes more important in surface area. Looking at it a little bit differently, this comes from a famous textbook by Murray of the normal lung. And once again, we can see the branch points here more in cartoon form. Here's the trachea. You can see the different branching points. The Z zone here is the transitional zone. We start going from purely conducting airways, those 2.4 kilometers. Now we're getting into the gas exchange surface area. We're getting to these transitional bronchioles. You can see the oxygen travels down these ducts, and in a fashion now where it's going to be taken up. I will say just a little trivial data here. This is where crackles come from, right here at the transitional zone. The lymphatic tufts, the little glomeruli of the lung, if you will, sit right in this area. These junctions down here, the interstitium is very tight, so fluid at least doesn't want to accumulate there at the beginning, so it tracks up into the terminal bronchial area and goes to the lymphatics, and pulmonary edema where the lymphatics are overwhelmed, then the fluid starts to accumulate here, the terminal bronchioles get sticky, and then when the person inspires, they snap open, and that's what we can hear. We cannot hear alveoli, folks, okay? This is where crackles come from. If we look at the scanning electron micrograph, I tried to depict this cartoon a little bit more in reality. Here we have the conducting airways, and then we have the acinar airways. Here we are in this transitional area. And you'll notice that they aren't like we see in the textbooks, like two little balloons connected in parallel. This is in parallel. This is really happening in a series here, and maybe depicted better here. So if you can imagine a bolus of oxygen starting up here, as it travels down towards the alveoli, oxygen molecules are being taken up. So in the healthy lung, by the time that oxygen bolus, if you will, or quanta or packet, whatever you want to call it, reaches the alveoli, there are a lot fewer oxygen molecules. This is a process called screening. And I can't get into it now, but it has some interesting physiological and pathophysiological implications. I've shown you the different branch points, and that straight line sort of assumes that the airflow kind of jets right down those conducting airways to the gas exchange area. But that's not really the reality. We have to worry about or understand that there is resistance along our conducting airways, and that it's not uniform, and that in actuality the resistance is highest at about the 6th to 7th branch points. This is around the 2 millimeter in diameter airways. Okay, this is where we worry about our asthma. This is where we worry about obstructive lung diseases. This is where we work so hard to try to reduce airflow limitation as much as we can in the appropriate clinical condition. But as you can see, as we go down in the lung branches, and you cut across the lung, the airway cross-sectional area increases dramatically. And when you have all of these little tubes in parallel, the resistance drops quite dramatically. So by the time you get down, to these transitional zones and down into the alveolar ducts and respiratory bronchioles, the airway resistance is actually quite low. And in fact, by the time we get into the gas exchange areas, air is no longer moving by bulk flow. It's kind of diffusing, Brownian motion, that kind of thing by the time it gets to there. Okay. Here's some interesting electron micrographs. This is a scanning micrograph here in the lower panel to your left. It's at 100 micron resolution. It just simply shows one of these respiratory bronchioles kind of opening up into a gas exchange surface area. If we look at this 10 micron resolution, I just wanted to make the point here that these are the capillaries, and you can see some red blood cells here, and essentially they line up one after the other. That's how you can get 194 mLs of blood spread out over a tennis court surface area, because the blood essentially is just red cells kind of lined up one after the other. They're not really stacked or packed on each other, which could actually be problematic in certain lung diseases. This transmission micrograph with a 2 micron resolution is just to demonstrate you've got 2 alveolar sides over here. Here's a red blood cell. This is the capillary. You can see that the membrane is very, very thin. 1 micron or less can separate us from the environment in our blood in the lung, 1/40,000th of an inch. Okay, I'll finish off with the physiology piece, if you will, by looking a little bit at what gas transfer means. This cartoon was actually developed to help explain the diffusing capacity maneuver that we do in the pulmonary function lab. You can see here this idealized alveolus, and you can see that this person is inhaling 0.3% carbon monoxide, which is what we do when we measure diffusing capacity of the lung. Breathe in the carbon monoxide, hold the breath for 10 seconds. The carbon monoxide zips across the alveolar capillary membrane, and we have the pulmonary arterial blood coming in here through this capillary, and it leaves out here nice and happy in red as it picks up its 4 molecules of oxygen per molecule of hemoglobin and goes on its merry way. And then when during this 10-second breath maneuver, the person exhales, we measure how much carbon monoxide comes out. We calculate a rate of gas transfer, which sort of reflects the efficiency of the lung to take up gas, including oxygen, which is what we're interested in today. And then we move on. And clearly, in certain diseases, depending on where the pathology is going to be, it's going to affect the gas transfer. So when we do a pulmonary function test and we measure gas transfer and we see that the DLCO is down, it doesn't really explain to us the histopathology or the physiology, the pathophysiology of the disease, because it could be because of decreased perfusion, perhaps a vasculitis or a pulmonary embolism. It could be a thickened membrane, and Dr. Roman's and my favorite diseases, the interstitial lung diseases, or it could be just a large surface area relative to perfusion, as one might see in emphysema. So all of these things we have to think in our heads when we see someone who's hypoxic. All of these things can result in hypoxemia, and then we have to calculate and decide how we're going to relieve that. Is it an acute situation, a chronic situation, et cetera? So I'll finish off this piece by showing you this graphic. I found this in an old monograph at Emory University. The library would literally throw out books they didn't want anymore kind of in the lobby, and we would all scramble and find things that we liked. And so I like this one, and I show this to the residents and fellows, and I really like it kind of sums up everything I've said, and plus more. So this is what was called the oxygen cascade. You can see that up here. And what we're looking at here on the y-axis are the millimeter of mercury in torr, right? So if you're at sea level and you've got dry air, you go to Florida, and then you take the air from Arizona, so you've got dry air at sea level, you're going to have all of the gases are going to add up to 760 torr. Now, oxygen is only 21% of all the gases that we breathe, right? So at sea level, under ideal conditions, this is air. This is where we start at the mouth, about 154, 155 millimeters of mercury. And then so I walk down this cascade, and then I kind of quiz the fellows and residents and students what they remember and know, and why they think that what is happening here to make the oxygen decrease as it moves from the mouth all the way down to the tissues. You'd be surprised how many students are caught off guard when I say, well, what's the fraction of oxygen in the air that we're breathing? They really have to sit down and think. It's something that I think we take for granted so much we don't really think about it much anymore. So once we get past that, then we can begin. So what's happening here? So we're breathing air at the mouth. It's about 155 millimeters of mercury. It gets into the trachea. There's a little bit of drop-off there. And then I ask why. Well, there's a little bit of water vapor pressure in the trachea and some carbon monoxide, right? So that's going to take up part of that fraction. It's going to decrease the fraction of PO2 at that point. And then we have this remarkable drop-off as we go through the conducting airways to the gas exchange area, and most of that is caused by water vapor pressure, which is normally about 47 millimeters of mercury in our nice, moist, warm lungs. Oops, or tie. So that's why we get there. So by the time that the oxygen gets to alveoli, it's at about 100 millimeters of mercury. All right. So if you can imagine, then think of all the different types of pathologies that can affect the conducting airways, that can affect the cascade at this point. You just think about them. I'm not going to talk about them. Just think about them. And then we get down to this crucial area where the gas exchange actually occurs. All right, this is the area where the diseases that Dr. Roman and I like to treat lives. And we have a gradient of 100 millimeters of mercury on the alveolar side. And on the arterial side, for various factors, we have this alveolar arterial gradient. It's about 90. And so we have a driving pressure of about 10 millimeters of mercury to get the oxygen into the bloodstream. It gets into the arterial blood, and of course it's consumed by our organs and muscles and so on. And if you were to measure a PO2 in the veins, it would be about 40 millimeters of mercury, and then the whole fun cycle begins all over again. All right, so let's talk a little bit about the things that we have to consider about using oxygen in the acute care setting. I'm going to show you a lot of pictures here, as I promised. But first, I'd like to make some points that are specific to the acute care setting. Typically, when we go to the emergency department or go to the hospital and we're having respiratory difficulty, we tend to breathe faster than normal. This is what Dr. Roman is doing right now, just sitting in a chair, resting quietly. Okay. If you look at this loop, on the y-axis, we have the flow in liters per second, not per minute, not like a 2 liters per minute prescription by nasal cannula. This is per second, so much faster than 2 liters per minute. So this is the inspiratory cycle. So we're starting from no flow, peak flow here, and then at the end of inspiration, we're back down to no flow. And then we exhale, and we have the same pattern here. Our peak expiratory flow is down here, also in liters per second, and then back. All right. You can see here, I'll just translate. This came from a British monograph, and they used kilopascals instead of centimeters of water, millimeters of mercury. But the bottom line is that it takes about 1 centimeter of water to move 200 mLs of tidal volume in a healthy individual, not breathing on a ventilator, that kind of thing. So it's very little work is required to move quite a bit of air. So that's important. So when we get sick, what happens? Well, here we are breathing nice and quiet. Here we may be coming with an infection. Something may be going on. So you can see that our respiratory rate is picking up. All right. So you have someone in the emergency department who's breathing hard and fast. Are you going to slap a 2 liter per minute nasal cannula, which I don't know why he's still wearing his, on this individual, or what's going on? It's like waving a fan in front of their face, right? If you got someone who's got 50 liter per minute ventilation because they're acutely ill, 2 liters per minute is 48 liters short. So you're going to get very little. So you're going to have to start thinking about other ways to deliver oxygen at a higher flow rate to meet the patient's demands. So we're talking about hospital oxygen. It's got to come from somewhere. We have many patients in the hospital who are using oxygen, so we have to make sure that we got plenty of it. All of you see this all of the time outside of the hospital. These huge tanks that look like they belong to the shuttlecraft. You know, the external fuel tank for the shuttlecraft. The residents at the VA park right across the street from one of these. The vendor comes in and puts liquid oxygen into these containers, and here are the valves that are used to put the oxygen in there. You'll notice the valves are dark. They're made out of brass, and there's a good reason for that, because brass is malleable. So if you take your wrench and you accidentally strike the brass, it's going to go thud. It's not going to go spark, because you don't want sparks around this terrible accelerant. Anything that's organic or is combustible around oxygen will immediately explode. So then this is obviously connected through lines into the hospital, and we deliver O2 through our wall. And this is a very standard wall mount that you see for oxygen and air delivery. Oxygen, by convention, is always green. That way you don't make a mistake and stick the oxygen on the air and vice versa. But even so, there's a backup system for that, because behind these panels, these are little bayonet mounts, there's a pin. And the pin here is at a different level than the pin for air. So if you have a therapist that's not looking at the wall and they're trying to put the oxygen regulator into the air, they won't be able to do it. That pin will not let them engage that mount. And it is the same for all the other gases, be it nitrogen or carbon dioxide or so on. The regulators have different pin systems or configurations so that you can't mix up the gases. Another little piece of trivia. Okay. So let's start out by looking at some of the low-flow systems. I'm going to go from low flow to high flow, and hopefully with what I've explained to you about how the lung works and how gas transfers and so on, you can begin to see how you might select the particular oxygen delivery system. What we have here in the green, this is the standard nasal cannula. It can go up to about 6 liters per minute off the wall. And the reason it can do that is it can only do 6 liters per minute is because the diameter of the tubing is such that if you increase it much more, the resistance gets high and it might actually pop off the wall. So the standard nasal cannula can get you up to about 6 liters per minute, which at times may not be sufficient. We see it at the VA all the time. We have patients who are maybe on home oxygen at home. There's patients with COPD. They come in with an acute exacerbation or infection or maybe a little heart failure, what have you, and we have to increase the amount of oxygen that they typically use at home. Failing this, we can use, and we don't use them here, we use them a lot at Emory. This is a high-flow cannula. As you can see here, the diameter is a little bit bigger. The prongs are a little bit bigger, so there's less resistance offered through the tubing. You can get up to about 10 plus liters per minute with this. What we see around here more often is these reservoir systems. We have the mustache catheter here, which is the one we most commonly use, and this is called a pendant catheter. And basically what's happening here is that these reservoirs of maybe 50, 75 cc's have a little membrane in the middle. So as the patient is breathing oxygen through the prongs, the continuous flow, there's oxygen that's filling up one side of these reservoirs. So then the patient can entrain from that as well as receive the flow. So they can get constant flow, but then when they breathe in, they entrain air from this reservoir, the membrane moves over, and it fills up with oxygen on the other side. So there's this constant motion back and forth as the reservoir fills and it's being emptied by the patient's inspiratory maneuvers. All right. Same principles for the pendant catheter. So this is something you may commonly see in an acutely ill COPD patient who's going to need higher levels of supplemental oxygen, at least while they're acutely hospitalized, and obviously our goal being to treat them and get them back to their baseline. This is a simple mask. A simple mask you're probably not going to see too often. You can get 15 plus liters out of a simple mask. It's okay for transport. You got some EMS may slap that on a patient very easily, and they can just crank up the oxygen, and it's okay to hyperoxygenate somebody while you're getting them to the ED. It's better to hyperoxygenate transiently than it is to hypooxygenate individuals. But it's not really a good device to keep people on when they're in-house, right? Masks are uncomfortable. There's the issue of heat. Some people feel that there might be some carbon dioxide buildup. There could be some issues with respiratory compromise. And if the patient is obtunded, you don't want a mask tight-fitting or loose in case they vomit or something. They need to be able to remove a mask. If they cannot remove that, they could drown. So you have to be very careful with mask systems. See, you guys don't think about this, right? We don't typically think about these things. So when we start, air is humidified, as you know, and we need humidified air for good mucociliary clearance, avoid desiccation, infection, that kind of thing. Once we start getting much above 4 liters per minute, and I should have mentioned that the gas, the oxygen that comes out of the wall is entirely dry. It has 0% humidity, because to create the liquid oxygen, you need to totally dehydrate the gas. Otherwise, you'd have ice. It wouldn't work well. So when we're going to 4 liters per minute of oxygen or greater, we tend to humidify that. These are just examples of bottles where we fill them with water. The oxygen is bubbled through the water. It picks up the humidity, comes out to the individual through these connections here. And all too often, I'll see patients on just dry air, and that's not a good thing over the long term. You may have seen these. We call them partial rebreathers or non-rebreather masks. Again, these are not masks that should be kept on an individual when they finally get up to the ICU. They're fantastic for someone who may be in the ED and it's very hypoxemic and you need to get their oxygen up, and to transport them, they're very easy to set up. The partial rebreathers call that because you see this bag? This is a bag that has a connection here to the oxygen. The oxygen fills the bag. The patient is able to breathe in and out, and there's an open orifice here, so the exhale breath, some of the exhale breath will get into the bag and mix with the oxygen that's coming from the wall, and that's why it's called a partial rebreather. You'll notice there's some ports on either side of the mask because the airflow rate here is not going to be enough to keep up with the individual's flow rates, and so we do entrain room air. So basically, and that's why I have this around sign, the partial rebreather, depending on how fast the patient's breathing, is going to give you an FiO2 somewhere around 60%. So in someone who's profoundly hypoxemic in the ED, you're trying to get them up to step down or the ICU, using a bag system like this is not a bad idea, but only for transport. Don't leave them on it. You can't humidify this because all the water would accumulate in the bag. It would be dry air. Hours and hours of dry oxygen coming into the patient is not good. This is a non-rebreather, and it's a non-rebreather because now instead of an open orifice, we have a one-way valve, so oxygen can fill the bag and you can entrain from the bag. But when you exhale, you cannot get the exhale gas back into the bag. All right, you can get about an 80% FiO2 here. You'll notice that there's a valve here on this port, so that when the patient inhales, you can't entrain room air. There's a port over here, and there's no valve on it, and that's deliberate, because if a patient suddenly starts to breathe heavier, harder, and heavier, they may not have enough flow rate coming in through the bag to suffice, and you'll need to start entraining room air. Then obviously the FiO2 will drop, but hopefully someone will catch it, the patient's getting worse, and take action. But again, I don't like to see these used in the ICU. They're fine for transport for someone who's profoundly hypoxemic, but don't leave them in the ICU with these dry systems. So what do we do to people, especially in the ICU, when they need high oxygen, that maybe they're breathing quite rapidly? You want to deliver oxygen at a high flow rate, and that's where we go to our Venturi systems. Okay, and this is a quick one that can be built in the emergency department. This comes in a little plastic bag, and you pop it open, and a bunch of these little things fall out. They're different colors, and I'll show you these in a moment. But how these work, they work on Bernoulli's principle, where you have a small orifice here, and you connect to the oxygen, and it jets oxygen at a very high rate through this orifice. And then you see these openings here. It creates a negative pressure inside of this device such that it entrains room air. And depending on how fast you're jetting oxygen through here, it's going to give you a specific FiO2. All right, and it'll tell you on the bottom of these things, it'll say 8 liters per minute, and then it'll say 28% FiO2. So you just have to adjust it to what it says on the bottom here. It's going through this corrugated tubing into the mask, and the patient's breathing it. You can actually add a connector here to add humidity. If you're planning to, if you don't have any other Venturi system that can humidify, you can actually, there are connectors that come with this. People usually look at them and go, I don't know what this is, and they just throw it over their shoulder because it's a funny looking thing. So this is good for transport as well. If you need high flows, you want to transport somebody that is dry gas, you don't want to leave them on it forever. These are just some of the different connectors that come with this kit, and you'll see here that it's 24%. This one is 28%, like the one I just showed you, attached 31, 35, etc. And you may wonder, how did they pick these funny numbers? And I think the person who designed these just had a sense of humor and just wanted to round off the actual fraction of inspired oxygen that you're going to get with each of these. You can see that it rounds into zeros or fives. So if you're on a 28% one, what's going to get down to your alveoli, remember with room air it's 100, it's going to be 150 millimeters of mercury. So that's what you're going to get. And of course with a 50%, you'll have 305 millimeters of oxygen partial pressure once you get down to the alveoli. So that's why they have these percentages, so it rounds up real nice when you do the alveolar air equation. So if you're going to have someone on a high flow system for a prolonged period of time, you want to go to a mist-type system, high-flow system. This device is one of many, just depends on what your hospital is buying, what they negotiated for. And this piece here actually screws on the top of a long bottle, and this little blue tube is actually like a long straw that dips all the way down into the bottom of the bottle. And in this bottle we have water, and the oxygen is piped in is bubbled through the water, and it comes out through this piece here, which through corrugated tubing and a mask then is delivered to the patient. This is a top view of this device. You can see here the FiO2 is going from like 30. It can go all the way to 100. And how does that work? Well, as you twist this, you have a different surface openings here. You can change the size of the opening. It will entrain air and blend it with the pure oxygen in different ways to get you the FiO2 that you want. Okay, I said it can go up to 100% FiO2, but nothing is for free. The higher FiO2 you dial in, the lower the flow rates go. So you really have to watch what kind of flows your system is delivering relative to what the patient is demanding. That's really the main point I want to make. Now, when someone is requiring very high FiO2s and they're breathing hard and fast, this is probably close to the edge of where they may need to be intubated unless you can turn them around quite quickly. And I'm not going to talk about invasive ventilation or non-invasive ventilation, assisted ventilation today. But I will get a little bit close. Some of you may be familiar with this. This is the high-flow nasal cannula system. It was initially developed for the pediatric world. You have a blender here where you can actually blend oxygen off the wall with the room air. You can get FiO2s all the way up to 100%. But the key thing with this is that it can deliver it at high flow rates. Now, in the pediatric neonatal world, we get it maybe to 6 to 8 liters per minute. But in the adult world, we can actually deliver up to 60 liters per minute of gas at various FiO2s quite reliably. I wanted to show you this so I can show you the setup. We have the blender here. It's very critical that when you blast this oxygen at such high flow rates that you actually humidify the oxygen and that you warm it up to room temperature. All right? And then it comes out to the patient. And you can see here this hapless medical student has been recruited for this photo op, but there are some problems here. You'll notice how stretched this tube is. There's a little thing that goes around the neck like this gentleman has. It's supposed to be around the neck to relieve the pressure. And that's really important. It's not trite because if you're blasting at 60 liters per minute, and typically we go 30 to 40, 50 in adults in the hospital, if these nasal prongs, which are a little bit bigger than the standard prong, are obstructing the nose, it could be a bad thing. I mean, your eardrums will pop out of your ears because you do want to have some room there for entrainment. You do need to relieve some pressure here because you do get some positive expiratory pressure and expiratory pressure with this device. Also, another problem is that this is only at 24.9 degrees. It needs to be at body temperature. My wife's making me go to Iceland this December, and can you imagine sticking your head out the car window at 60 miles an hour? It's not going to feel very good, but if you go to Florida where it's going to be 98 degrees and it's fully humidified air, it's going to feel a little bit nicer than a full blast of air. So it's very critical that this be brought up to body temperature before you put it on the patient. It's very critical that you set the cannula correctly, and it's done with this little neck piece that you can string it out like a necktie, or one of those Western ties, to make sure that it fits correctly. So our respiratory therapists need to gain competency in this. And the use of this high-flow nasal cannula, there's a lot of interesting literature out there, and it's only about 8 years old in the adult world, so we don't have all the information in yet. But people are trying to use these things to avoid having to go on a ventilator. They're also trying to use them to get them off ventilators sooner. Maybe we're bridging into and bridging out of assisted ventilation. But they fail. There have been some papers which show a nice little audits of their particular organization, and they can see that some of these people fail and end up on mechanical ventilators. So the recommendation currently is to use this system only in step-down or ICU situations where you have to be well monitored. You cannot use them on a regular floor. And we don't do that at the VA, and I don't think that we do that here at the university as well. But very interesting system. Just kind of a summary of some of the things that the high-flow nasal cannula can do. It can deliver a high FiO2 because the high flow, it minimizes room air entrainment. Okay, so what's happening with these high flows, you're actually washing out the nasopharynx and the oropharynx, and even some of the dead space in the trachea. So then when you inhale, you're already inhaling from a reservoir of oxygen. All right, so some dead space is washed out. You can generate some positive airway pressure. Even with the mouth open. If with the mouth closed, for every 10 liters that you bump up on this high-flow cannula system, you can increase PEEP by about 0.5 centimeters of water. With an open mouth, it's about 0.35. So you do get a little bit of positive end expiratory pressure. The idea and hope being that maybe in someone with congestive failure, you can bridge them. You can get a little bit of PEEP. You can improve. You can recruit alveoli and so forth to improve oxygenation. And then also the idea being that you might be able to decrease the work of breathing. So people with COPD may have this auto PEEP that are built up. So if you're kind of negating some of that auto PEEP with high-flow nasal cannula, the work of breathing will decrease. And they are comfortable. I've actually tried one of these. I couldn't believe it when I first saw these. I said, come on, 60 liters per minute. It's going to just, my eyeballs are going to pop out. And I put it on. It was extremely comfortable. And, of course, it allows unimpeded oral intake. Instead of having to use a high-flow mask with cold water coming into your face for hours and hours and maybe even days on end, you can use the system which allows better care for the patient. Caveats, the use of the high-flow nasal cannulas I mentioned to delay or avoid intubation or to try to get people off sooner can have some drawbacks. I mean, you need to have experience with these devices and to better use them, because you may have to turn around and intubate somebody unexpectedly or re-intubate somebody unexpectedly. Okay, so I'm going to finish off by talking a little bit about the oxygen in the ambulatory setting, which I think is really important because many internists out there are prescribing oxygen, but I don't think that they have a sense or a visual in their brains as to how this happens and what are all the things that go on behind this. And there are a lot of things that do that. There are about 6 million Americans on supplemental oxygen in the home. It's a little bit over $2 billion in cost to maintain that. So it's important to get the right person on the right oxygen if they need it, because if they don't need the oxygen, they're carrying around tanks like that. Dr. Roman, he's going to wear it all day long, I think. And it can be a burden as well. And if you don't need it, you shouldn't be carrying it, and it also costs money. So I'm going to talk briefly about these two gentlemen that really had an impact on oxygen use in development in the United States. Dr. Alvin Barak, or Barich, I'm not really sure how that's pronounced, was in the early part of the 20th century and brought oxygen to the hospitals in the 1920s. You know, those oxygen tents, that kind of thing. It was developed by Dr. Barak. And during World War II, he was involved with the masks that the pilots would use, and he took some of that technology and brought it back to civilian use and was starting to develop all these masks and things that I've been showing you for use in the hospital state. He also is the one who started to develop the small portable oxygen tanks. Okay, but it really wasn't until this gentleman, Dr. Tom Petty, in the 1960s, when he was a fellow and mentored at the University of Colorado by Dr. Roger Mitchell, his mentor, said, look, there's this thing called, we got astronauts now going up into outer space, and there's all this really interesting oxygen technology. Why don't you get some of that technology, bring it back, and let's see what we can do for our hypoxemic patients. So what Dr. Petty did, and with the advantage of not having IRBs at the time, he was able to get COPD patients that were quite advanced out of the public, off the street essentially. They were hypoxemic, they had cor pulmonale, and they were polycythemic. Okay, so he brought them in and said, hey, come over and stay in our clinical trials unit for a month. I'm going to give you lunch and dinner and all that. And he did right heart catheterizations and did some radio labeling and was measuring red cell mass and so on. And so he was the first to demonstrate that indeed a PO2 of around 55, corresponding with a saturation of around 88%, this is where we would begin to see pulmonary vascular constriction. It was these folks who would have increased pulmonary vascular resistance and so forth that he found with the right heart cath. And he found that by giving them oxygen, cathing them at the beginning and at the end of that month, that he was able to decrease the pulmonary arterial pressures and also polycythemia began to resolve and so on. This was done in a small handful of patients. His studies were recapitulated in Great Britain, and then there are the two famous studies that came along that every pulmonary fellow should have in their back pocket. And these are the two studies that were done really performed in the 70s, but reported in the 80s that now describe the reason that we prescribe oxygen like we do. And I'll show you that in a minute. This was a study that was done in Great Britain. It was done at 3 places in the UK, only 87 patients, and they took patients who were, like Dr. Petty's, hypoxemic with cor pulmonale, really quite advanced COPD. They gave them oxygen, and for the sake of time, I'm not going to go into a lot of detail, but this is the famous survival curve that they've shown, and you can see on the y-axis is the percent of patients surviving, and here we have days from admission to trial, and we're looking at over 5 years here. These are studies that have to be done over a long period of time. And well, you could see that it was really around the 500 days of starting oxygen compared to no oxygen whatsoever, which is the dashed line, is where we started to see the survival benefit. The survival benefit really was seen much earlier in the women who were participating and later in men. No one really knows why. But they also they did right heart catheterizations, they looked at red cell mass, and they could see, similar to what Dr. Petty described, was improvements in those areas. Now, in the United States, almost simultaneously, a trial was done, although in the U.S. it was felt to be unethical not to have a group that didn't have oxygen. So I don't know if that means that Americans are more ethical than the British or just less brave in doing clinical trials. Come on, guys, wake up. But this trial pretty much looked at people using nocturnal oxygen only compared to continuous oxygen therapy. And they also found a difference. And here we have about 4 year difference or so on. And you can see here that nocturnal oxygen is here, nocturnal oxygen only, and survival for the 24-hour oxygen individuals was better. It doubled the survival by the end of the trial. And actually, they had little timers and things to monitor the oxygen. On average, they really used oxygen only about 17 hours. It wasn't a full 24. So even with the 17-hour use in these hypoxemic people, they did get a survival benefit. So these two trials are the ones that today we describe the parameters that we need to use to give oxygen. We have a diagnosis of COPD, cor pulmonale, ILD, CHF. And by the way, all of these studies were done in patients with COPD, not in any other diseases that produces hypoxia. We just translate that information or that data into all of the other diseases that cause hypoxia. It makes sense intuitively, but no one has ever really done a trial to see if oxygen helps a person with idiopathic pulmonary fibrosis. Although the hypoxemia can be eye-opening, and we still give it. So basically, we need to, for payment by Medicare, we need to document this, a PaO2 of 55 or less, like Tom Petty found. This is an empirical number, not a guess. And then there are certain situations depending, there's a little bit of wiggle room. You see 56 to 59 if the patient has cor pulmonale, et cetera here, polycythemia, that kind of thing. If their PaO2 is around 60, you have to have very compelling medical documentation. You have to write a letter to have the oxygen paid for. How do we decide how much oxygen a person needs? Well, we want to do it typically under stable disease conditions, right? We get an arterial blood gas on air. If they're on supplemental oxygen, we take the oxygen off and we measure the arterial oxygen. If it's 55 or less, they automatically qualify for supplemental oxygen. But obviously, when we exercise and when we sleep, things change. With exercise, obviously, we increase our minute ventilation. We require more oxygen, so we have to test patients with what we call a modified 6-minute walk test, where we walk them and increase the oxygen incrementally until we find a flow rate that's going to suffice to keep them above 88 for at least 6 minutes. At night, we tend to hypoventilate. We don't breathe as deeply. Our thorax takes a little bit of a break, so we do experience hypoxemia and some hypercapnia naturally, even in healthy individuals. So sometimes if you're really picky, you may want to do nocturnal oximetry and titrate based on that. Or some people say just go ahead and just increase it by 1 liter per minute with sleep. And if you don't want to do the 6-minute walk, go ahead and increase it by 1 liter for exercise. And obviously our goal is to make the patient feel better and hopefully survive longer. I wanted to talk, this is a journal club on a slide, basically. This is hot off the press. And I think it's really, really important. I know we're going to journal club this to death in pulmonary. Everyone's invited. Dr. Roman's buying lunch. But this is a study that was just published in the New England Journal of Medicine. The question that they asked was, well, we know that 55 or 88 or less that people will benefit from oxygen. But what about that gray area, those people that have moderate desaturation with COPD? Are they going to do better? So in a nutshell, this was a 6-year parallel group study using supplemental oxygen versus no oxygen in stable COPD patients who had resting oxygen saturations here in that gray area, above 88 but still down, still low, or if they desaturated with exercise, as you see here. They powered it up for about 738 patients, and they got them. They did it in 42 centers. It was a well-designed study. And the primary outcome was to determine if supplemental oxygen in this population led to a longer time to death or first hospitalization from all causes. Did it prevent death? Did it impact mortality? Does it impact all-cause hospitalization? There were some things that went on during the trial, so they really broke it up into 2 groups. They had a resting group, which were the ones that were below 89%. They received 24-hour O2 at 2 liters per minute straight up versus no O2. Then they, again, in people who were in the 89 to 93. I should say 89 to 93. Then they had the exercise group, the desaturators. They gave some oxygen and they gave some none. Okay? And the bottom line was that the time to event analysis showed that there was absolutely no difference between intervention and the placebo groups. I couldn't download for some reason the graphics, the Kaplan-Meier curves, but they sit right on top of each other. There was absolutely no difference in the primary outcome. And there were a variety of secondary outcomes, including quality of life measures, that also there was absolutely no difference. So the conclusion was that, well, this is a negative study, right? We're not going to be able to help these people. But I really see it the other way around. We can actually help these people because right now we are prescribing oxygen for people with COPD who have okay resting saturations but who desaturate with exercise. And I know of the 600 people I have at the VA, probably a good third of them are desaturators. They're fine at rest. So just think about it. How much money could we save? How much trouble could we save individuals from having to haul around tanks? If we have this data and if it's validated and And no one in Journal Club can convince me otherwise that we shouldn't rethink this. So this may be a very important study moving forward. Okay, I'll finish off mainly with images, so it should be fairly quick. This is a concentrator. I show that to the residents and fellows and students and so on and say, this is a concentrator that gives people oxygen. It's good up to about 5 liters per minute. And so how is the oxygen made? And they look at me and they go, magic? Well, no, it's not magic. This schematic sort of describes that. This is just a very, I really like this because it's very simple. So we have the room air gas here. It's filtered first by this compressor, brought into the system, and this is to capture the dust bunnies and any hapless insects that might want to get into the system. The air is pumped into these columns which contain aluminum silicate or zeolite. Okay, it has very high avidity for nitrogen. So as the air passes through this column, the nitrogen is adhered to these beads, and the oxygen goes into this reservoir here, which is oxygen enriched. And it's really pretty good. Even up to 5 liters per minute, you can get about 89% pure oxygen into this system. Now, what's happening here is as this column is getting saturated with nitrogen, this column has just kind of been waiting. Okay, so when this column is completely saturated with nitrogen, there's a backflush of pure oxygen through this, which flushes this one out. But meanwhile, this column has taken over the job of creating the oxygen. So this is called a pressure swing adsorption system, a PSA system. So it goes back and forth, back and forth. And a standard concentrator is going to last about 5 years, 25,000 hours for the patient. Okay. Now, if you want to go into the oxygen-making business and you've got about $100,000 laying around that you just want to use, and you can clean out your garage, you can actually get this system here because this is how we're going to make the oxygen that's delivered to the hospitals and delivered to the patients. And by and large, it uses the same PSA system I just demonstrated to you. Oxygen is everywhere. It's in the carpet, and in compounds and so on. We can extract it from many different things, as they're hoping to do on the moon or Mars someday. But we're getting it out from the air here. And basically, this is a schematic that shows these large aluminum silicate columns. It's very, very important to dry the gas extremely well, because when you cool these things down, you're going to have ice mixed with liquid oxygen and so on, and other gases. You've got to scrub out the argon and other gases that are in there. That's where the quality control comes into play. And then this cryogenerator, it's like distilling things. Everything freezes at different points, and what you're doing is you're picking out the liquid oxygen freezing point, you store it, and then you can deliver it to the home or to the hospital in the different forms that you might want to select. I show you this because the concentrator in more recent years has become smaller, and these are portable, but for oxygen concentrator, size matters. In the large concentrators, we can deliver constant flow of oxygen, so if you've got 3 liters per minute, it's true. But when you've got a small concentrator here, you can't generate the oxygen fast enough, so it does it in a pulse fashion. It'll generate a blob of oxygen, and then when the patient inhales, they get a little packet or quantum of oxygen. And there are settings on this, the settings 1, 2, 3, 4, 5, 6, and each of the settings gives you a larger packet of oxygen, but you cannot equate that to liter flow per minute. And typically, and in many cases, what you do need continuous flow to keep the oxygen saturations up. So you have to be careful when you use a portable oxygen system. Here are the tanks, the E-tank that Dr. Roman has. It weighs about 15 pounds in its aluminum form. You can put 2,000 psi into these before they explode, and you can hold about 640 liters of oxygen in these tanks. Okay, so do the math, as I'm going to show you here. I'm going to skip that. This is a chart. Here's our E-cylinder, weighs about 15 pounds. It holds around 625 liters of oxygen under 2,200 psi, and at 2 liters per minute, it's going to last about 5.1 hours. And there are different sizes of tanks. because an E-tank you can't carry. It's a little heavy. So there are smaller tanks, but obviously the smaller they are, the payback is you have less oxygen. Like this D cylinder only has 359. You'll notice this H cylinder weighs 135 pounds, and it can hold this much oxygen, and it's good for 57 hours. And this is something that we take to the individual's home in case the electricity goes out. Their concentrators don't work. They have a backup system, and an H tank is a common one to use. But you can see the different size tanks here. I want to show you this to make a couple of points. I told you my images wouldn't be as gross as Dr. Callan's, and they're not. I don't see any brain matter or blood on the hood of this car, so thankfully someone was not sitting in the passenger seat here. But I dare say that there's a nice big brown spot on the seat of the driver's side. But I like to show this image here because it reminds us that when we deliver oxygen to the home, there's a large safety feature that the companies, the vendors have to undertake. Basically, the patient is signing a contract. I'm not going to smoke when I use oxygen. And believe it or not, a lot of patients still smoke are on oxygen. They want to make sure that there are smoke detectors. Are there electric heaters? How do we store the tanks? If they're going to be upright, they have to be chained to the wall or in special carriers. If they're going to be horizontal, they have to be underneath a sofa or something so a person can't trip over them. So there are a lot of details that go on into delivering oxygen to the home setting, and safety is one of the major ones. We constantly oversee the vendor at the VA that we're using to deliver oxygen to our veterans. Different setups in the home. This is called a home fill system. This individual is getting oxygen continuously from the concentrator, but there's this compressor device here and a special tank with a connector that's being filled at the same time. So after a couple of hours, this portable tank can be filled so that they can take that around with them. So instead of having 30, 40, 50, 60 tanks at home, they can have just a handful of these and just keep them refilled and fill at home. And so this is a nice, more recent system. Sometimes we need higher flow rates. If we're needing 4, 5, 6 liters per minute, especially in our patients with interstitial lung disease, a tank compressed gas is going to run out quite quickly. So we have liquid oxygen systems. These big thermoses are about 150 pounds of liquid oxygen in these that are refilled about twice a month in the individuals who have them at home. It costs about twice as much. Logistically, it's just more expensive to do liquid oxygen. But when you need high flow rates, sometimes we'll go with that. This cutaway view shows one of these systems. You got liquid oxygen here. There's a vaporizer coil so that the individual can use this in the home with a 50-foot long cord. And then they have a coupler here that they can fill these portable systems and carry them around. So 1 liter of liquid oxygen is about 810 liters of oxygen at room temperature pressure. So again, an E cylinder is 625. 1 liter of liquid oxygen is 810. So you can see that there's a lot more oxygen in a smaller volume when we use liquid oxygen. A little bit about the oxygen conserving devices. We already talked about the reservoir cannulas, and here they are again. So I'll just go straight to this graphic here. So if you have someone that's going to need a high flow rate and they need somewhere around 5 liters per minute, you may opt to go with one of these reservoir systems. So if you put that at 2.5 liters per minute, you're getting a 50% savings, but you're in training from that reservoir, so you get the same benefit as getting continuous 5 liters per minute. So one way to enhance oxygenation for patients who need high flows is to use a reservoir system. Some people work, some people like to travel, and if they can, we go to conserving regulators. This is the one we use at the VA. You can see here the different numbers, and this, when you have it set here, the individual inhales, and that's the only time that the oxygen is delivered. You hear these little puffs, these little psh, psh, when the patient inhales. You can also go to the setting, which is going to be continuous flow, but obviously the tank will run out faster. So again, we have to test patients in these pulse modes because it may not be sufficient. But that's one way to conserve oxygen. This is a system we haven't seen out yet. It's going to be, I guess we're a little bit behind our endocrinology colleagues, where we can constantly monitor the blood sugars and deliver insulin depending on what the blood sugar is. This is a system whereby hopefully in the short future we'll be able to measure oxygen saturations continuously, and then the oxygen delivery will be adjusted to that. So if you can imagine the oxygen saturation's fine, you're not wasting any oxygen from your tank here, and it should allow the tank to last much longer. But that technology is not out for use yet. It's quite bulky. I'll leave that alone. So I'm going to finish off by the last technique that we might be using in the outpatient setting. And I've done this a few times. Our patients with interstitial lung disease tend to be quite hypoxemic. And a transtracheal system sometimes is the way to avoid having to use very high flow rates coming in at the face. And basically all of this hardware and stuff here and is geared to getting this little thing that sits here right here in the trachea. It dangles just above the carina, and it in essence flushes out the trachea, so you get a reservoir effect. And you can take someone on 5 or 6 liters and take them down to 2 or 1.5 liters, even by using a transtracheal catheter. There are some problems using it that I won't go into, but it is a technology we can get to. So that's all I have for today, and I'm happy to answer a couple of questions if anyone has any. Thank you very much.
Well, thank you. You are correct. I am sticking with my oxygen today. So some years ago in the mid-90s, as you know, I was in the VA system in Atlanta, and we were asked to do the numbers on how much oxygen and so forth. And actually, the delivery of oxygen in hospitals is like cents, But once you get somebody ambulatory care, and it becomes very expensive. And it turns out, we actually calculated that the dollars used to provide was the most expensive drug delivered in the entire hospital. And that is why today it is an over $2 billion enterprise. And it's all about the drivers and the trucks and the tanks and all that kind of thing. It seems to me that we don't spend a lot of time, even though that is incredible, we don't spend a lot of time thinking about this. And we often, the residents and we as physicians also often prescribe without thinking about the mobility of the patient. Do they have the capability of putting a tank where it needs to be and so forth? How do we get everybody to understand what is the appropriate way to prescribe this? Yeah. Or is there the most common, easy way that fits 80% of the population?
Yeah. Well, I think a simple answer would be to let only pulmonologists who understand these systems and what they mean to prescribe oxygen, because there are many people out who are on oxygen who, when they come to the VA, for example, they're veterans, they want to get their oxygen, quote, for free. They don't qualify for oxygen anymore, and they're very disappointed. So I think we have to be very upfront with our patients, especially in the acute care setting, and say, look, you need oxygen now, but it'll be great if we can get you home without it, or if you need it for a little while at home, that's okay, but if you don't need it anymore, we're going to take it away from you, because it's amazing how many people have become so dependent on it psychologically. So we have to be very careful with that. I'm really amazed in the outside how some third-party payers will pay for oxygen when the patient clearly doesn't qualify. Somehow that happens. I don't know. The VA were extremely strict. I mean, you have to meet the numbers. If you don't meet the numbers, you're not going to get the oxygen, and then that can be some area for consternation. So I think up front we have to understand better how to speak to our patients about delivering oxygen, get them to the right place. At the VA, we check everybody on a regular basis, and some people come off the oxygen, and we congratulate them. That's how you have to approach it. But the VA is very efficient using oxygen. In relative terms, we're about $1 billion cheaper than Medicare. We're very strict in the VA. Medicare is a little bit more loosey-goosey. Yeah.
Since you started your career in 1987, it seems fast clear about that. It's a very specific question. In the smoker COPD patient,
yeah.
What have you seen are the two most interesting developments, treatments, medications, and how is the disease different here in current time versus late 80s with the COPD patient?
Oh. So we're going away from oxygen now, or do you want some opinion? No. Gosh, no. The patient is the same patient. We understand now better, especially with high-resolution CT scanning, that there are different flavors of COPD. We have the centrilobular, we have the bullous, we have the paraseptal, which have some other implications I don't have time to get into now. The drugs are basically the same. We've had beta agonists and actually ipratropium or the muscarinic inhibitors came out a long time ago. Theophylline was used for many decades, even before these drugs came out, and now there's some PDF4 inhibitors now along those lines that are being used, Frumulas and some of these others. So different delivery systems, different types of things have made it a little bit more complex to deliver these medications. So yeah, there's been some improvement, but the bottom line is you got to quit smoking. The interesting thing about oxygen is, and it's still quite controversial, and I don't know that anyone can ethically do the study, but is a person who's hypoxemic and still smoking, are they getting benefit from oxygen? And no one really knows that. What's really interesting is if you're polycythemic, you stop smoking, you get oxygen, the polycythemia resolves. If you get oxygen and you continue to smoke, the polycythemia will not resolve. I don't know what that means, but yeah, so that's where we are.
Questions, comments?
Thanks.
Well,
everyone.
Just one final point. There are 55 million smokers, most of them in Kentucky for some reason. Okay? There are 20 million COPDers. Once you have severe COPD, once you get diagnosis, that day you have 50% survival at 5 years. You have severe COPD, which usually is an FE1 around 1 to 1.2 liters. That day you have a prognosis of 50% survival in 5 years. This is a big deal. This can enhance that, so delay that prognosis, and we need to know how to use it. Thank you. Have a good day.
Okay, take it off.
Rob.
Sure.